thing with the sound she'll get.
She was a parent.
All right. Thank you all for coming out tonight. Thank you all for coming. We're thrilled to have you here at the Gilford Library, and we're thrilled as well to have Raymond Suarez coming over from LRGH to talk about dementia and memory loss. It's something that we all hear about, read about, want to know about, and today we have a chance to hear from an expert working in the field. So please let's give a warm welcome to Raymond.
I like to have this completely laid back. If you guys need to get up, use the restroom, need to leave, that's totally fine. If you have any questions during the lecture, please feel free to interrupt me. I would prefer to have more question and answer, because that's what this is about, is to answer your questions for this topic. A little bit about me. I work for Lakes Region Mental Health, formerly Genesis Behavioral Health, and they subcontract me out to the hospital, so I'm the chief of psychiatry at Lakes and Franklin, and I do the geriatric psych unit at Lakes. And I don't know if you guys are aware of that, but it's a small unit, it's a 10-bed inpatient unit. We do from 55 and older now. We just...
Speak up a little.
Oh, I'm sorry. If you can't hear me, please don't feel bad to interrupt me. So Lakes Region Hospital has a geriatric psych unit. It's an inpatient unit, 10-bed unit, 55 years and older for any psychiatric diagnosis, but primarily we do dementia patients there, and we handle the behavioral issues that come along with that. So that is an option for you guys if you have family, friends that need some help.
I have a microphone if you'd like to use that. Would that be easier for you?
Sure. Can everyone hear me, or do you need a microphone?
Be good for a microphone.
Okay.
I'll set that up. We can keep going.
Okay, so the lecture today is going to be about dementia, primarily going to focus on Alzheimer's disease. That's the most common form of dementia, but there are a lot of different types of dementia, and we'll go through all of that. So what is dementia? So dementia is a catch-all terminology. It's an umbrella phrase. Overall, it encompasses diseases, conditions that have a decline in your memory, in your language, and problem solving. So it's not just memory, and that's sometimes people get confused with that. You need to have deficits in all of these in order to have the diagnosis of dementia. And it affects the person's ability to perform everyday tasks. Every diagnosis in psychiatry, that's the most important part. So if it's not affecting your day-to-day life, it's not really a problem. We don't need to necessarily treat it. Is this better?
Yes.
Okay. So as I was saying, if you're doing okay, then it's not necessarily a problem that needs to be treated. But I'm going to talk about some options that we have and how to recognize it early on. So what's in the name and why is it important? So dementia literally means without mind, the dementia. And it's mostly associated with elderly, but it's not only elderly people that can get dementia. The term senile, from the Latin senilis of old age, is the other term, the older term used for dementia. Mostly associated with Alzheimer's, and again, that's not the only diagnosis that goes under the umbrella of dementia. It has a negative connotation, and that's the importance of the name. Because we are currently trying to change that connotation by changing the name of dementia. So you may hear different names now, and I'll go through some of those with the new nomenclature in medicine. And it's mostly associated with severe memory loss. Not all of these things are true, and that's why it's important to talk about what dementia is. So the DSM, which is the quote-unquote Bible of psychiatry, that's what we use for all our diagnostic material, came out in 1952. It did recognize that dementia was an illness that needed to be taken care of. It came under the title Disorders Caused by or Associated with Impairment of Brain Tissue Function. So that was the subtitle of that. They were categorized with impairment in orientation, in memory, and intellectual functions such as comprehension, calculation, knowledge, and learning, an impairment of judgment, and lability and shallowness of affect. So that's your mood going up and down. So even at that time, they recognized that dementia was a complex disease. It's not just about memory. There's a lot of different things that are going on. It was further categorized as a chronic brain syndrome associated with senile brain disease. Again, these are a lot of antiquated terms, but that's how psychiatrists would diagnose people. You also have to remember at that time, there really was no treatment for dementia. So the reason it was kind of the stepchild of the psychiatric world is because there's really nothing that they could have done at that time. And once they got diagnosed, it really was mostly the end stage of dementia. So you can see here just by the classification, and this is taken directly from the DSM. This category is designed for classification of organic brain syndrome occurring with senile brain disease, whether this be mild, moderate, or severe. Later goes on to classify it, and it's what we would call today all severe cases of dementia. So it says these cases vary from mild organic brain syndrome with self-centering of interest, difficulty in assimilating new experiences, and childish emotionality, up to and including those so severely affected by senile brain disease as to require institutional care. Nowadays, this entire category would be considered severe dementia. Deterioration may be minimal, or it may progress to a state of vegetative existence with or without superimposed psychotic, neurotic, or behavioral reactions. So as dementia progresses, you can get these symptoms like psychosis that come along with it. And again, that's more towards the end stage. So this was 1952. Fast forward to 2000, DSM-4 at this time came out, and it had different categories of dementia. And again, I just focused on Alzheimer's type here, but they kind of fleshed it out a little bit more. And you need to have both of these. You need to have memory impairment, and you have to have disturbances with language, your ability to carry out motor activities, failure to recognize objects, and difficulty with planning and executive functioning. So executive functioning are the things that would help you to balance a checkbook or do complex type tasks. Now, why is all this important? So getting back to the name, so dementia again has a negative connotation. You know, you hear it in the kids now, they call each other demented when they do something silly. And because of that, because of the negative connotation, it stops people from getting help. People are afraid to have that title of dementia. So finally, for the first update in 27 years, in 2011. So for 27 years, nobody has really put any research or effort into progression of the field. But in 2011, the National Institute on Aging actually put money and research into this, and they came up with more research, and they changed the name. In 2013, our DSM-5 came out, so that's our current DSM manual, and they renamed dementia as neurocognitive disorder. So you may hear this, from the doctors on the charts. They most likely will not say dementia any longer. They say neurocognitive disorder, and it's a fancy name, but it does it captures what dementia is. Through the rest of this lecture, I'm going to go through and just use the word dementia because that's the more common one that people know. But just to be aware that now it's called neurocognitive disorder. They also made a distinction between mild neurocognitive disorder. So again, as I was saying before, previously, dementia wasn't recognized until it was very, very severe. Now we're able to recognize it earlier on, and there's things to do that can slow the progression of the illness and help people to be prepared for what may be coming. So the changes that happened, neurocognitive disorders are now characterized by cognitive impairment as a defining feature. So you have to have problems with your thinking. Cognition is your thinking. And it emphasizes that it's a brain disease. So there's an organic cause. There's a disruption of that function, and it results in measurable symptoms and a decline from previous function. that's different than neurodevelopmental deficits, which are present from birth. So it's different than any kind of brain injury that may have happened since birth. And as we know, it develops later on. So these are the cognitive domains. There's complex attention, which is your ability to pay attention to this lecture. There's your executive functioning, and that again helps you with your planning, your decision making, your working memory, your response to feedback, inhibition, and mental flexibility. The inhibition is a big one because that happens a lot. And you might notice in loved ones and friends where people start saying and doing things that they didn't do before. You recognize that this is not the person that I know. And that is a key function of dementia.
Do you have some like concrete examples of what you would hear?
So, I mean, that's a very good question. So oftentimes we'll have people who may be these sweet church-going little old ladies that come in, very nice, never cursing or anything, and they're swearing like sailors. Or they're saying sexually inappropriate things. Whatever comes to their mind, they say. The way that, and we'll go a little bit off the lecture because I think this is important. The way that Alzheimer's disease works is, think about your brain. There's a bunch of neurons in your brain, and that's the roadmap for all your functioning. And when we're born and we're developing, those roads are completely clear. Traffic is moving beautifully, very quickly. Then with Alzheimer's disease and most of the dementias, there are proteins that get put down in these roadways and block them. So think about the roadways. Now there's a tree that fell down in one of the roadways. Well, traffic's going to slow down, but you still have alternate paths. So you can still function. But then another tree falls down, and then there's an accident somewhere, and traffic slows and slows and slows until finally there's no alternate pathways, and that's when things start going wrong. And that's what you're seeing as dementia progresses. You're losing these functions slowly.
What are some things that people can look at initially in their loved ones that might be inappropriate, or just, like, so you're saying they're not themselves, but we can just say, oh, well, they're just not themselves. So what are some things that you've seen that by the time they get to you, or even in a mild, like maybe a routine checkup, and you're like, oh, and no one brought it up, and you're like, well, is this normal? Like, have you, I don't know if I'm being clear enough.
The biggest thing from spouses or children or people that live with the loved one is irritability. That's one of the biggest things that people complain about. So they get very snappy, and they, mostly it's because they're trying to cover up things that they don't know. In normal functionings, oftentimes I'll be in the hospital and we'll do an interview for a patient, and we recognize that something's not right, and then we'll check their memory and we give them a diagnosis of dementia, and the family's shocked, and they're saying, well, something happened. You must have did something to the patient because they weren't demented when they came in, so what happened now? And the truth is, in everyday life, we cover up for each other. So if I couldn't find a word for something right now, and we were having a conversation, you would fill it in for me, and we would just keep the conversation moving. And you wouldn't know if I didn't really know the word, or if it's just I was thinking about something else and it slipped my mind, and that's it. We don't ask each other, what's today's date? We don't question things. And we also have these memorized patterns of our everyday behaviors. So, if I say, hey, how you doing? The normal response is, I'm fine. And you keep it moving. We don't really stop to check in and ask. And if you don't know the person well, you don't even know the facts of what's going on. And sometimes people can make these things up and you wouldn't know. Then when we start talking to the family more, they'll go back and they'll start looking at the checkbooks and like, oh, well, look, they haven't paid these bills in a while and that's not really like them. Or this is the woman who always remembers everyone's birthday and sends a card and hasn't done it this year. And these types of things are noticed. But the irritability is a big thing because when people start realizing that they're confused, they get anxious, they get irritable. Sleep is another thing to look for. People will start to have changes in sleep. And as we age, our sleep pattern changes. We don't get as much sleep, and we don't need as much sleep as we age. You'll start getting these early morning awakenings. That's something else to look for. But that can be associated with a lot of different things as well, especially depression. And this is the time of year when seasonal affective disorder will start coming in. But these are the kind of things to look for, just the irritability, maybe impulsivity. They change they start spending money that this is a person who always saved up, and now they're spending money frivolously. These types of changes. If you notice that it's not right, it's worthwhile to stop and ask and just look further into that. So just to move on is learning and memory, just being able to remember things, language, naming. That's a big one, and we all go through that. You forget, what's a common word for things. But with dementia, you may lose the low frequency words on every day. So low frequency objects would be, what's this part of the tie called? And the answer would be a knot. The reason it's called low frequency is because you don't use it very often. And those are the things that you start to lose first, but you would remember that this was a tie. And so in a normal everyday conversation, that would get you by. You may remember that this is a watch, but you can't say that it's the face of a watch. And these are the types of things that a doctor might ask you in the office just to kind of flesh out what's going on. Perceptual motor function, that's a big one. That's why people start to get lost. And they go outside their house or they go to an unfamiliar environment and they can't find their way back, because that's a part of the brain that starts to be affected with Alzheimer's disease. So you will notice that people will be getting lost more often, usually in newer places. So if you have a road that you traveled your entire life, you can go back and forth and not have a problem. Now all of a sudden they have an alternate route and that person gets lost. Social cognition, so recognizing emotions in other people and having insight into your own emotions. Again, getting back to the irritability, these are things that start to decline. So mild neurocognitive disorder, this is what we want to recognize first, because this is where we can have the most impact with people. Once you have a severe form of dementia, there's not much to do. The treatments that we have are not great at this time. They cannot reverse anything, but they can slow the progression. So if we can recognize when these things start, we can intervene. Now, it's very important. So it's the same criteria, but at this point, it's not interfering with your daily function. And so people, especially protective factors for dementia, would be intelligence, because we learn to get around the system. So, for example, if I didn't know what today's date was, well, I'll just look at my watch and give a clue. If I needed to remember, which I did, when this lecture was, I put it in my calendar. And you can learn to do things like that. So you'll notice people may be putting more Post-its up around their house. The refrigerator has all these notes on it. And when that happens, it's not a problem, and it may not even be dementia. And again, we all do it, but it might be something just to look into. So for the major, again, what needs to happen is that it causes a problem in your everyday life. So now you're starting to forget important things. You're not going to places that you're supposed to be going to. You might notice that people aren't taking care of their hygiene as much as they used to. That's another very common sign, but that's very late in the illness. People aren't very aware of themselves. They're not showering. They're not taking care of their clothes. And it's not because they're forgetting to do it. They can't remember how to do it. There's a bunch of steps that go into all of these things, and people can't remember those steps. So again, dementia is an umbrella term. It's a big term for a lot of different things. These are some of the types of dementia that you can see.
What were some of the methods that you have for helping slow the progression of dementia? You mentioned that you had some.
So I'll go through those. Those are in the
Okay.
towards the end, but yes, that's important. So these are the different types. Alzheimer's disease by far is the most common type. about 60% of all dementias. But there's other types. Frontotemporal dementia, Lewy body disease, vascular disease. Vascular disease is another big type of dementia. That's caused by insults to the brain. So if people have cardiac issues or they have strokes, TIAs, that's where you'll get the vascular dementia. Why is that important? Because vascular dementia, if you control the risk factors, you can stop the progression of the vascular dementia. So of all of these, vascular dementia is really the only one that you can stop in its tracks if you can control what the risk factors are. Can't reverse it, but you can slow it down. So that's why it's important to just get your regular checkups, make sure your blood pressure is okay, make sure if you have to take cardiac medication, take it. Traumatic brain injury, if you get into any kind of accidents, substance use can cause dementia. Medications, when they say medications, some of the medications in high doses, which would be abused, can cause some types of dementia. Alcohol is another big one that can cause dementia. Prion disease, that's things like mad cow disease. I don't know if you've heard that, it was in the news a while ago. Parkinson's disease, as Parkinson's progresses, it can cause dementia and cognitive deficits. Huntington's is another one. And then there's mixed versions from other medical illnesses. But Alzheimer's and vascular dementia are by far the most common ones, followed by Lewy body and frontotemporal. So here, this is just saying that where Alzheimer's is between 50 and 70% of dementia, usually in 65 and older. Once you go below 65, you're looking into other types of dementias like Lewy body disease or vascular disease. Parkinson's disease is another one that we'll see as it progresses. So this is just another slide just showing, this is for people who are over 65. So the incidence, they say, is about 5% of the population at 65, and it pretty much doubles every 5 to 10 years after that. So your risk, the biggest risk factor for dementia is aging. You can't control that. Everyone ages.
Early onset Alzheimer's, is that different?
Yes and no. So early onset Alzheimer's disease usually is hereditary and can progress relatively quickly. Most of the time for just typical Alzheimer's disease over 65, it's a slow progression through the rest of the lifetime. It can be relatively quickly, but majority of people, it's a very slow progression. The earlier onset ones usually are more rapid, but tend to be not necessarily Alzheimer's. There are other, like the Lewy body disease is another one. The problem with a lot of the research is that, as I showed you before, for all this time, nobody was doing any research, so everything was just Alzheimer's. If you had dementia, it was Alzheimer's. And no one really looked further into that. Even today, we can't definitively say what the dementia is unless you do a post-mortem biopsy of the brain. That's the only way to show definitively that it's a specific type of dementia. Other than that, we kind of guess, and based on clinical presentation, of where it fits best.
You may not know the answer to this is out of my curiosity. Are the studies that have been done for Alzheimer's since 1952, are they primarily with white males? Or is it now a little bit more spread out with having some females and having just a general population, like what a real population looks like versus just males?
That
Like
I don't know the answer to, but with the Alzheimer's, it always affected both males and females, so they would have been in the original studies. As far as the other demographics, I'm not sure. And this, unfortunately, doesn't show up here, but this is for under 65. So you can see under 65 Alzheimer's drops down to 33%, and vascular dementia kind of jumps up a little bit more. So again, Alzheimer's is the most common type. It's a term for memory loss and other cognitive abilities, and it accounts for between 60 and 80% of all dementia cases. It's not a normal part of aging. That's the other part that people don't realize. That there are some normal memory loss that comes along, but Alzheimer's disease again, is more than just memory loss. There's things that come along with it, with the inability to do complex tasks and language, which is not part of quote-unquote normal aging. The majority of 65 and older, but about 200,000 Americans under the age of 65 have the younger onset Alzheimer's. So it does affect a lot of people. It's progressive, and again, as I was saying before, as these plaques get put down in the brain, it starts blocking all your passages. And in its early stages, it's pretty mild and is easily missed, but it's the 6th leading cause of death in the United States, and on average, after diagnosis, a person will live 4 to 8 years with Alzheimer's disease, depending on a lot of other factors, because as medicine is getting better, people are living longer and longer, and you can live up to 20 years depending on those factors.
I'm surprised when I hear Alzheimer's referred to as a cause of death. How is that?
It's a very good question. So as dementias in general progress, people lose coordination with their muscles. They forget how to do a lot of things. The best way I can describe it is dementia takes you back in time to infancy. And if you think about all the milestones that happen from when an infant is born until adult life, those slowly get peeled back, and pretty much in the same order. So as they go back to a newborn, they lose even that ability to be coordinated for suckling. And so people start choking. They can't swallow food, they aspirate, they usually get pneumonias and that sort of thing. So Alzheimer's itself doesn't cause death, but the complications from the Alzheimer's cause people to pass. So there's no current cure, but we do have some treatments. And again, the treatments can't stop the progression, it can slow the progression. Unfortunately, the only treatments we have right now are for Alzheimer's disease. So the other dementias we do not have any treatments for. The medications that you'll hear about, and I'll speak about some of them in a little bit, things like Aricept and Namenda, those are specifically for Alzheimer's disease. Any other type, it's not going to help. Vascular disease, again, if you stop whatever the risk factors are, you can stop the progression. But that's really the only thing that we have. There is research underway. The newer research, there is some research that looks kind of promising, where they try to break up those plaques and tangles that come into the brain. That may be helpful. I'm not 100% convinced that it will help, because I think of it as breaking up the blood clots in the heart after someone has a heart attack. So yes, you cleared up the vascular system again, but that muscle's already dead. And so I'm not sure that how much it's going to help with reversing any symptoms, but it may help with the progression of symptoms. So again, these are just the symptoms of the dementia: trouble with thinking, planning, memory loss, difficulty communicating and understanding conversations. Another thing, just thinking, in the patients I take care of, you'll see patients that will just kind of nod off. They're not really sleeping, and you know they're not sleeping, but they kind of nod off, and that's their way of just checking out, because they really don't understand what's going on, and rather than engage in a conversation, they just pretend like they're sleeping. That's something that you might notice as well. Changes in behavior, restlessness, aggression, struggles with day-to-day tasks, problems with orientation. These are the things that we find. Warning signs, again, it's the same as the symptoms: confusion in time and place, changes in personality, changes in mood, poor or decreased judgment, difficulty doing familiar tasks, problems communicating, misplacing things. We all do that. Forgetfulness that affects a day-to-day function, and difficulty with planning or problem solving. Once you start withdrawing from work or social activities, that's really having a big impact on your life, and that's when I would say it's really time to get help. So how do you find out if you have dementia or if a loved one has dementia? there are some screening tools, and you'll see the MiniMental is a very common one, clock drawing. Simple as that, draw a clock. And to me, that's one of the biggest things that I can do to see where a patient is with their cognitive functioning. And unfortunately, my generation may be the last one that knows what a real clock looks like. But that being said, you ask someone to draw a clock, the way you do it is you just say, you can give them a blank piece of paper, draw me a clock, make it big enough so you can put the numbers. Put the numbers, but don't put the hands yet. See if they can organize that. And from there, then you ask them to put the hands on the clock, see if they know which is the minute, which is the hour hand, and you give them a complex thing, so something like 10 past 11, where you have to figure out what 10 past means, and then put that on the clock. And these are the higher functionings, and you'd be surprised, people who can have a very normal conversation with you will look at the paper and be very, very confused. So that, in and of itself, is a very important test. The Montreal Cognitive Assessment, that's what I do for the majority of my patients. It's a very good test. I'm going to take you through that test in a few minutes. MiniCog is another one. Some of these you may never see, but just in case the doctor says one of these tests, most of the ones you're going to see are the MiniMental and the Montreal Cognitive Assessment. The MiniCog is quick. That's an easy one for your PCP to do. You ask the patient to remember 3 objects and repeat them later on. You ask them to draw a clock, and then they repeat the 3 objects. So it takes under 3 minutes, and it allows you to see, it's just a screening tool. Doesn't mean that you have dementia, it just means that it's a screening tool. So we do further tests. The MiniMental, it's a 30-point test, so it takes a little bit longer. A score of 24 or less suggests a neurocognitive disorder or a dementia. Relatively sensitive, but not specific. So that means that it gets a bunch of people who fall under the category of dementia, but it doesn't mean that if you get 24 or less, that you have dementia. It could be something else that's going on. One thing that's often overlooked is what we call a pseudo-dementia, a fake dementia that comes along with a mood disorder, especially depression. So if somebody gets very, very depressed or very, very anxious, they're going to do very poorly on these tests. And you'll see that a lot, especially with grieving. When people get very depressed because they're grieving the loss of a loved one, they may appear to be demented. But the reason it's called a pseudo-dementia is that once that mood disorder goes away, the dementia goes away. And again, as I said before, none of the other dementias are reversible. So that means it's not really dementia, it's because of the mood disorder. But that is something to consider. This is what a MiniMental state exam would look like. The doctor would ask you, what's the year, the season, the date, the day of the week, the month, where are we right now? And that's graded on a 5-point scale. They give you 3 objects and ask you to remember them. And then you do what's called the serial 7. So you start at 100, subtract 7 from that, and keep going. And you can't write it down, it has to be done in the head. Alternatively, you can spell the word world backwards. You ask them to remember what those 3 objects were, see if they remember them. You show them objects like a wristwatch, a pencil, and ask them, what is this? You ask them to repeat, no ifs, ands, or buts. And that's seeing if people have what we call an aphasia, the inability to speak. So you want to make sure that they can hear you correctly and repeat correctly. You give them a complex task, a 3-step task, like take this paper in your right hand, fold it in half, place it on the floor. You write down on the back of the paper, close your eyes, and ask them to do what this says. So that's seeing if their system is working. Can they read that and do what it says? You make them write a sentence, and then you have them copy those, the interlocking pentagons. So again, score of less than 20 or 24 suggests mild dementia, and it goes down from there. The Montreal Cognitive Assessment is a little bit better. That's a test that I prefer to use, and it has a bunch of different forms that you can use so that you can follow a patient throughout time. So it prevents people who have just a mild dementia from memorizing the test and doing it again the next day. So this is what it looks like. The first part with the circles and with the letters and numbers, that's called the trail making test. You ask the patient to connect those dots in ascending order, alternating between numbers and letters, and the first two are done. So from 1 we go to A to 2, and so on and so forth until you get to the end. Then you ask them to copy the cue, which seems like a simple task. However, when people have dementia, they don't see that as a cue, because think about it, it's not a cue. That's just a two-dimensional object. Our brain is telling us that it's a cube, so we're able to interpret it as a three-dimensional object, and then we can copy that object. So oftentimes what you'll see with someone who has dementia is they'll start copying the little pieces of it. So there'll be a little triangle, and then maybe a little diamond, and then they'll put another little triangle, and they're trying to piece it together because they're not seeing it as a cube. There's a clock drawing test, naming of objects. The most common thing that everyone says the middle one is a hippopotamus, but that's the most common one. You ask them to repeat the words after you. They don't get any points for that, but you tell them that they're going to remember that for later on. You ask them to do digit spans forwards and backwards, just to see if they're paying attention. The ability to concentrate for long periods of time is with the next test, where you say, I want you to tap your hand every time I read the letter A. And you go through that whole list of letters. By the end, if someone has dementia, they forgot what the original task was, and they're just tapping all the time, or they just stop tapping completely. Serial sevens is again part of this one. Repeating the phrases, they have to repeat them exactly. You can't give them any points if they don't. Fluency. So you say, I'm going to time you, and in 1 minute, I want you to name all the words you can, in this case, that begin with the letter F. And then you time them to see how many words they can get. Again, it seems like a simple task, but as dementia progresses, the fluency of words goes, and people may start saying more simple words, or they may not be able to get even 11 words in 1 minute. Abstractions. Tell me what's the same about these words. So for example, if I say banana and orange, you would say fruit. We don't count things that are called concrete answers, which is what you would get when you have advancing dementia. So train and bicycle, we're looking for transportation. People might say they have wheels, and that's what we would call a concrete type answer. Then we see if they remembered any of those 5 words from before. If they don't, so you only get points if you remember them without cueing. But again, as I said before, we all give ourselves cues, so I want to see if you're able to remember with cues. And so I'll give you a category cue. So if the word was face, I would say it's a part of the body, and that may jog your memory. If they can't get it with that, you give them a multiple choice test. So you say, okay, was it face, was it arm, was it leg, and see if they remember from there. And then orientation, just to see if they know exactly where they are and what's going on. These are just different forms, so you can see that the shapes change, the animals change, so that you can continue to do this through time and test patients as they progress. Now this was developed for people who have an education. If someone is not as educated, or if they're illiterate or blind, you can do the MOKOB, which is this, again, testing the same thing, but a little bit more simple. So this is a good one for patients who have dementia. So that's a big mess of objects. And in order to be able to pick out all the different objects, you need to stop the rest of the noise that's going on. And as dementia progresses, you can't do that. This is more of the MOKOB. So how to protect against it? Things like this are very important. Staying active socially, reading, doing puzzles, things that stimulate your brain are very important. Meeting friends and being social is very important. Doing crosswords. Crosswords are very, very good for language and helping with dementia. So these are the medications. So you'll see there's Aricept, Exelon, Namenda. Those are the 3 big ones that people will use. Most of them now are Aricept and Namenda. They're cholinesterase inhibitors. The brain acetylcholine is a neurotransmitter in the brain that helps people to pay attention. And the brain then sweeps that up and gets rid of it because it doesn't want too much in there. But the problem with dementia is that there's not enough. And so these inhibitors stop them from sweeping it up. So you can think about it like there's little pieces of dust on the floor and you come and you sweep it up every day and the place stays nice and clean. But if you need that dust there and you're sweeping it up, then that's a problem. So if we just stop the sweeping, the dust will build up. So those are the cholinesterase inhibitors, or things like Aricept and Exelon. Namenda is a different type. It works on the NMDA receptor, which is a receptor in the brain that's important for a lot of different things. But basically there's a malfunction with that in dementias. And so that works on there and helps that to function correctly. They're not great medications in my opinion. However, they can help, especially if you get it early on. And again, it only works for Alzheimer's type dementia. So that's the important part of figuring out what the type of dementia is, because there are side effects to all these things, including nausea, vomiting, diarrhea. People can get more agitated on these medications, and so that's something else to look for. So that's what we have. Unfortunately, that's all we have right now. Other things you might see as people progress with the illness, and we'll add things like an antidepressant, which will help with the anxiety, will help with some of that agitation. They might do a mood stabilizer, and that's more towards the end stage of the dementia. So that's all I have in terms of the presentation. I did bring some handouts for diet that may help for dementia. It's not great, however, you can do things like the Mediterranean diet, which can help. So that's things, you want to have the virgin olive oil and fish and things like that, nuts. And there's some recipes in there as well for healthy eating. You're going to look for things like medium chain fatty acids. So if you can replace your regular cooking oil with coconut oil, that's another thing that can be helpful. Advanced directives. So I don't know if everybody in here has advanced directives. If you don't, I highly suggest that you do them. New Hampshire is the only state that requires something called an override clause in your advanced directive. So an advanced directive is, if you cannot make decisions for yourself, who do you want to make decisions for you? For medical, that's fine. But in New Hampshire, there's a carve out for dementia and for psychiatric care. So as a chief of psychiatry at the hospital, oftentimes I'll run into a problem where a patient may have advanced directives, but they don't have that override clause that says, even if I am incapacitated because of dementia, I can be hospitalized against my will. If that's not there, I cannot hospitalize you against your will. So we'll have people in the emergency room that need to be hospitalized for psychiatric reasons, but I can't do it because they're saying I don't want to go, and I can't help them because of the advanced directives. I have handouts in the back. So Lakes Region General Hospital, the social work department there will help you to do your advanced directives and file them on record at the hospital and with your primary care. And their contact information is back there as well. So that's very, very important. I suggest, no matter what your age, that's a very important thing to do.
You had mentioned the possibility of having something that would break up the proteins that are blocking it. How you were skeptical, not thinking that they might be able to help all that much. Is there any other remedy in the near or far future that you're hopeful might come about?
Not that I've seen.
Can you repeat the question?
Sure, I'm sorry. So he was referencing, I said that there was treatment, and the treatment was done on monkeys where they use ultrasound to break up the plaques that are in the brain. And it works, and it will break up those plaques. I wasn't hopeful because I believe that the damage is already done by that time. To my knowledge, there's nothing that's very hopeful. However, they're looking more at genetics, because if you can stop that protein from being laid down, then you can stop the progression of the illness. And there are some genetic testings. There are some forms of Alzheimer's that you usually the younger versions, that you can get genetically tested for, but most of them, it's just a random mutation.
Is or an MRI, does that fit into any of the diagnosis
Very
of
good.
anything?
Yeah, so,
Having an MRI?
so when you go to the doctor, part of a workup for dementia is ruling out any other cause that could be presenting this way. Part of that would be doing a CAT scan and or an MRI of the brain, checking vitamins like B12, folate, doing just a general workup for your thyroid, making sure that your electrolytes are doing well, that you don't have an infection. Urinary tract infections, especially as we get older, can be horrendous in terms of what happens with psychiatric causes. So it's not uncommon for me to see someone come into the emergency room that is acting completely agitated, psychotic, and it turns out it's just a urinary tract infection. And you treat the urinary tract infection and all that behavior goes away, especially if you have dementia. Anyone who has dementia are very sensitive to urinary tract infections, so they want to make sure that none of that's going on. That being said, a negative MRI or a CAT scan does not rule out a dementia. A positive one could help you to identify something, so I might be able to say, based on the MRI, I think it's a vascular dementia, or based on the MRI, I think it's a frontotemporal dementia, but having a normal MRI or CAT scan doesn't say you do not have dementia.
What's the link between a UTI and dementia?
Honestly, I don't know. It's just the infection. I mean, infection anywhere can cause it. Sometimes even the antibiotic treatment can cause some psychosis, especially things like Cipro, that can cause some agitation. But I don't know. I don't know what the link is.
But it's usually
very
an
common.
older person?
Usually it's an older person. You don't see younger people with the psychosis unless they have some abnormality with their brain, like if they have a traumatic brain injury or something like that, then they're more sensitive. But yeah, I honestly don't know what the link is.
You were talking about genetic testing to a certain extent. I know somebody who had that 23andMe that they did, and when it came back, it said they had a 0.04% risk of developing Alzheimer's. Is that something to be concerned about if somebody finds that, or?
So again, and this is why I don't like doing tests that you don't know what you're going to do with the answer.
Yeah.
Because the general population, so there's always a norm that goes in, and the problem with these tests is you get things done and then it doesn't mean anything out of context. So my questions would be, how old is the person? If you're talking about a younger individual, like an 18-year-old.
Late 20s.
So that's something then I would just be mindful of, but I wouldn't be overly concerned. So just to have that in the back of their mind, and then that's something that you would want to make sure that you don't drink, don't smoke, have a healthy diet as much as possible, exercise. But that being said, I've had patients on the unit that have had amazing lifestyles. One guy was running 18 miles a day and swimming across the lake, and then all of a sudden developed dementia. So I think, yes, you want to take precautions where possible, but you also have to be real and enjoy your life. You're not living in a bubble. And so, yeah, I have something I would just keep in mind, but not necessarily do anything about.
Okay, thank you.
I think one possible connection with the UTI in the brain, there's a lot of research now with the vagus nerve, with the gut-brain connection, and I think that might be how it connects.
I mean, it's possible. I mean, we see florid psychosis with the UTIs. And again, it's a well-known thing. I mean, it's so well-known that the ER docs, when someone comes in like that, that's just part of their routine to go through. And they won't even call psych until after that's done. And it clears up relatively. And the other weird thing about it is that it doesn't even need to have an elevated white blood cell count. Because usually we think, well, it's a really bad infection and that's what's causing it, but it's not. They can have a normal white blood cell count and just a UTI and have these symptoms.
Are they doing any more research about what causes are, because it's like you were saying, the guy with the superior looking lifestyle and boom, that happened. And then there was the nun study that they were doing of nuns in their 90s and people that looked like they should develop Alzheimer's didn't, and those that looked like that they should, that they had Alzheimer's.
Yeah,
You know,
so-
it was vice versa, and they couldn't tell exactly who was going to get what.
Yeah, and so that's the problem with these genetic things, where it's pretty messy. So it's part nature, part nurture. So people are predisposed to something, but it doesn't necessarily mean that it has to express itself.
Right.
And then what are the triggers? Again, we guess at a lot of things, a healthy lifestyle or unhealthy lifestyle, that type of thing. But so you can think of it this way, that if you're predisposed to having damage to your brain, you want to protect that as much as possible from any other damage. So you don't want to smoke, you don't want to drink. Although a glass of red wine, the data goes back and forth about whether or not to have that. If you look in the back, that's Alzheimer's diet, and they recommend having a glass of wine every day. So it goes back and
Doctor, go
forth.
home and have a glass of wine.
But a glass of wine also will decrease your stress, and so there's that too. And so you have to look at it, it's multifactorial, unfortunately. With the Alzheimer's, we do know that it's because of these proteins that are being put down in the brain. Same thing with Lewy body, there's Lewy body proteins that are being put down in the brain. And those are expressed on your DNA. Why that's causing problems, I don't know, other than it kind of mucks up the system by being there.
When you're actively dealing with someone that has dementia, or my dad, I believe, has Lewy body, and the repetition, how do you stop? The repetition can go on for hours.
It can, and so there's a couple of tricks that we use sometimes, depending on the patient, but you can sometimes just keep index cards and write down the answers to whatever the most common questions that they have are, and have them hold on to that. And then have them look at it, and they learn to look at the index card before they ask the question. That works with some people. Sometimes you just have to go with it. Never argue about any of these things with people. So don't say things. Oftentimes we'll have people that will say, oh, well, I'm leaving the hospital, my mother's coming to pick me up. I'm not going to argue with them that that's not happening. We just say, okay, well, when she gets here, we'll let you know. But right now, let's do this, and kind of deflect it and go into a different direction. Those are delusions that people have, and delusions are fixed false beliefs, so you're not going to change it. The repetition part is just because they're not remembering, and if they don't have that short-term memory, which goes to the long-term memory, you're never going to teach it, which is the problem. They can't learn new things. But sometimes if it's in front of their face, like they have that little notebook or that little ring with the cards on it, they'll look at it. Because we have these reactions to things. If I hold my hand out, you'll shake it. If I take a piece of paper and I just pass it to you, you'll take it. These are just responses that we have that are so ingrained in us that if I have a stack of cards in my hand, I'm going to look at what they are. And so that can kind of be helpful. And again, everybody's different, but these types of things are sometimes helpful. If you're worried that you have somebody that's wandering at home, that's a big thing that we deal with. Unfortunately, there's nothing to do for that, but you can alarm the doors, so just get chimes that go on the door so you know when they leave.
We put a bell on my sister's ankle. She had her daughter sleeping with her, but she didn't always wake up. So if she started getting up and wandering because locked doors were way far at the end of the house, just put a small bell on a little thing around her ankle and she didn't notice the bell at all,
Right.
but it alerted us that she was up.
Right, so it depends. You can buy pressure pads that you can place on chairs, you can place on beds, so when people do get up, it sets off a little chime or alarm, so you are aware of that. Disconnecting the battery to the car is another big one. So if there's somebody that you don't want driving, if you just disconnect the battery to the car, it's very easy to do, it's very easy to fix when you want to drive the car, but they don't think to check the battery, they just see that the car's not working and then they don't have nowhere to go. These types of things. There are resources out there as well that can help. There's visiting angels, there's people that can come into the home to help with respite type care, because it can be very taxing. We have the dementia unit, but we have shifts, and we're each there for 8 hours, then we go home. When you're doing care at home, it's 24 hours a day, 7 days a week. Things you don't even think of, like, well, when are you going to use the restroom? When are you going to take a shower? When are you going to go to shopping? These types of things are very difficult to do, but there are resources out there. There are people who will come into the home relatively cheap that can stay with the clients. Sometimes you can go to nursing homes and do what's called a respite stay. So if there's something like a big family event that you need to go to, but that person can't go to, and you don't want to leave them home alone, you can do a respite stay at a nursing facility. Doesn't mean that they're staying there, it just means that they're going to be there temporarily, like in a hotel, and then they'll come back home. But again, things like advanced directive, financial planning, if you do know somebody that has the diagnosis of dementia, financial planning is key. What a lot of people don't realize is that Medicare does not pay for nursing homes. Medicaid does, but Medicare does not. And so that means that all of these nursing homes would be out of pocket until you have enough or lack enough money to qualify for Medicaid. But these types of things, the financial planning part of it is a big thing. And Medicaid looks back 5 years on your finances. So the earlier you start doing these things, the better off that you'll be.
You mentioned traumatic brain injury, and in this case it's the frontal lobe, so that's the memory area. Is there a gradual progression of loss in that case?
With a traumatic brain injury, usually it's one and done type thing, where you have a motor vehicle accident or something, stroke, and it's done. But there can be some loss of brain tissue around that, which can progress slowly. The frontal lobes, which you brought up, which is the most important part, because that's where you get all these behaviors from. So it's not necessarily memory. It does have part of memory, but that's where the behaviors are going to be most affected. So the frontal lobes are what stop us from doing our animal instincts. So if I get angry at somebody, I may want to hit them, but I don't, because it's not appropriate at that time. What stops you from just urinating in the corner? Well, it's not socially appropriate. But if I was an animal, then that's totally fine. And our frontal lobes are what gives us our social norms and stops us from doing things. But you can think about being intoxicated. So when people are intoxicated and they say and do things that they normally wouldn't do, that's what happens with dementia as it progresses, especially with the frontal lobes. It's a lot, I know. I am available anytime you guys want. I work at the hospital. You just have to call the geriatric psych unit there. They know how to reach me. My wife works here at the library, and you can ask her to get in contact with me. I left some handouts in the back for to do your advanced directives with the social work department at the hospital. They know how to reach me. And we do have, Lakes Regional Mental Health does have a neurocognitive team now, so they can help with people in the community. And just because you come to an emergency room does not mean that somebody's going to have to go to the hospital. It doesn't mean that we're going to force somebody to go into a nursing facility. So don't be afraid to reach out for help, and it's better to do it sooner rather than later. And you're not alone. That's another big thing.
Thank you very much.
Thank you.
Thank you.